Welcome to Premier Pain Talk, a podcast dedicated to expanding awareness about treatment options for people in pain. Each week, host Dr. Michael Danko from the Premier Pain Treatment Institute in Cincinnati, Ohio, will discuss cutting-edge treatments for pain management that are improving the quality of life for those suffering from chronic pain. Tune in now to learn more about how to relieve pain and restore your life.
Hello and welcome to another episode of Premier Pain Talk. I'm your host, Dr. Michael Danko with Premier Pain Treatment Institute in Cincinnati, Ohio. We have 4 locations in Mount Orb, Loveland, Middletown, and Hillsborough, Ohio. With me today, I have 2 fantastic providers from our practice. I have April Egbert and Lindsay Link. I'll tell you a little bit about myself, and then I'll let each of them introduce themselves. Today, we're going to be talking a bit about some perceptions, or really rather misperceptions, of pain management and what we do as a specialty, hopefully to help those who are less familiar become a little more comfortable with what we do in our practice. But I'm a board-certified anesthesiologist and pain medicine specialist. I did my training at University of Cincinnati before going out in private practice in Cincinnati, and then eventually opening our practice, PPTI. Going to kick it over to April, let her introduce herself.
Hi, I'm April. I've been in pain management for 8 years. I received my master's in education and nurse practitioner at Northern Kentucky University, and just recently finished my doctorate's degree about a year ago.
Lindsay?
I'm Lindsay Link. I'm a physician assistant. I went to undergrad at Northern Kentucky University, and this is kind of my second calling in life. So I'm pretty new into the PA world. I went to Mount St. Joseph University.
All right. And so overall, I think maybe I'll kick it to Lindsay to start with, since you're the newest to pain management of the 3 of us. But when you were maybe going through PA school, when you're starting to get in the job market, or maybe in your first calling before you even got into the medical field, if someone mentioned pain management to you, or said something about pain management, what would be your first thought, or what did you kind of expect this specialty to be?
I mean, the first thing that comes to mind is medication. I think that's a little bit of maybe the time in which I had grown up, and not having an extensive history, thankfully, in needing pain management myself. But you think it's somewhere to go to perhaps get medicated, or even to a certain extent, maybe even thinking about people who are more into like a palliative care kind of a circumstance. I don't think I necessarily thought of it as the average everyday person who has had a back surgery and it didn't quite get them where they needed to be. So of course, like probably a lot of folks, my mind went more to the medication side of things.
Yeah, and really in our like you mentioned, some of the climate in our country, I think medication also will get confused with pill mill. And so for those of you not really familiar with what a pill mill is, that's really not a medically driven practice. That's really a practice that's almost a form of drug dealing, where a clinic will try to set themselves up as far off the grid as possible, so they're staying out of the eyes of regulators, and they'll generally just charge cash. They won't go through insurance, and they'll have people come in and get prescriptions and for cash, and it's a really quick kind of turnaround. And given the kind of the rapid speed of volume they try to do that kind of led to the term pill mill, or coined the term pill mill. And it's a terrible place. It's a place that our practice will never be, and I never want to ever be associated with. Thankfully, we're nowhere anywhere close to that, and we work very differently in terms of how we treat pain. So as we work into other options for pain going outside of medications, April, if you can rewind the clock a couple of years, when you're thinking about joining a new practice, how much familiarity did you have with what pain management did from a procedural standpoint? Were you aware of really much we did procedurally?
The only thing I was aware of was just your joint injections or cortisone injections. I guess that's what most people hear. That's what I heard in working in ER, working in the hospital settings. This is what I heard of. So coming into working in pain management, it was definitely eye-opening to see the options that patients have available to treat their pain, depending on what they were coming in for.
And so as think back myself, so I finished at anesthesiology at UC in 2012, and then I did my pain fellowship in 2013. I didn't have much experience with pain management. I really didn't know too much about it. I was doing my anesthesia rotations, and there was an opportunity to do a rotation in our chronic pain clinic, and that was like a rotation that each of the residents did. And I went in there and I spent a rotation in the clinic, and I started to see all the procedures that we were doing, the epidural injections and spinal cord stimulators and radiofrequency ablations, a lot of the treatments that we do. And I was like, oh, cool, this is a great specialty. Like I'm going to be getting to to have a little more longitudinal care with people. I'll do some treatment, see how they did. One of the things about anesthesia is it's a very kind of isolated event kind of specialty. So I would see someone for surgery. I'd do their anesthesia through that surgery, and then they'd go to the recovery area, and I never really knew what happened to them. So I didn't see, did that surgery work? Does that surgery not work? How are they doing down the road? Like it was very kind of at the point transactional, and didn't really have any longitudinal aspect to it, which can be really good because when you leave, your work is done. But there is some nice parts about that, but it was a little unsatisfying. And when I saw chronic pain management, I saw that it was a specialty where we got to see more how people did. So we'd do procedures, we'd follow them up later in clinic, see how they worked. If it didn't work, we'd make a different plan, and really went into more of a traditional kind of medical management type of role with seeing how they were doing with the continuity of their care. And so when I went into my fellowship, we would do mostly procedurally, and then if someone needed medication, a lot of times back then the primary care doctors were prescribing it. And so primary care doctors would be writing the pain medication for the patients, and they'd send them over to the pain clinic for their epidurals and other things. And then as the pill mills were starting to get found out and cracked down on, and there were a lot more regulations and laws and things that got passed as far as regulating who could and couldn't prescribe. It really morphed our specialty until when we were hybrid. We were doing both the medical management and the procedural aspect of it. So it's kind of funny, but when I rewind the clock in my own brain, like my perception of pain management was literally 180 of what the rest of the world kind of perceived pain management as. And I looked at it as a heavily interventional practice. So rather than letting me monologue this whole time, April, why don't you tell me what's your favorite procedure that we do at PPTI that is not a medication-based option, an interventional option that we offer patients?
I have two of them. So I would honestly say trigger point injections are one of my favorites, help with muscle spasms, muscle tightness around the neck, the mid back, the low back. And one of my other favorite ones are radiofrequency nerve ablations that we do for people for degenerative spondylosis of the spine. I think seeing that the longevity of that injection work with people has been pretty rewarding so far.
Yeah, so an ablation, that's a kind of a generic term in medicine, but in our specialty, we do something called a radiofrequency ablation, which is primarily for joint pain. So if you have pain in your low back that's related to arthritis in the back and the joints in the low back that really hurt when you're twisting and turning and bending and sitting for long periods. We do ablations for the cervical spine, the neck. We do it for the shoulder. We do them for the knee, the hip. It's a procedure that's pretty ubiquitous in terms of the areas we can treat, and pretty typically the duration of relief is at least a year with those ablations, and it's repeatable. So it works great for a year, be done again another year to keep it going. And we were part of some research studies recently that we were showing, pretty sustained relief through 2 years with that, which shows both the initial treatment working and the repeat treatments working. Lindsay, when you hear the word epidural, prior to pain management, you might have just thought about epidurals happening for pregnant women in the hospital. So, how is an epidural that we do for pain management different than an epidural to help someone have a baby?
I'll tell patients a lot, same sort of parallel, right? That when you hear epidural, you think childbirth. And I say that that's more speaking anatomically, about where it takes place. And, just kind of describing the fact that it's a way of putting medication to a specific area. And so, it makes more sense to put medication where it directly needs to be rather than taking medication that goes through your entire body. So yeah, that's kind of my differentiator is saying, everyone's taken medication for some reason or another to help relieve pain, but doesn't it make more sense to kind of focus the where the problem area lies? So, and that just kind of means going into a specific region that can be identified based upon the clinical symptoms or based on imaging or whatever the case may be, in order to offer relief to the patient, calming down inflammation, and even having the anesthetic used at the time is a bonus too. But explaining the difference between, we're not acting on the nerves that cause you to, we're not going to try to make you not walk, or feel anything below your waist. It's more about delivering medication in a more direct way to the problem area.
Yeah, absolutely. And so, targeting treatment to get rid of inflammation related to a back problem, versus numbing the whole back and belly and everything to try to block contractions. So it's a very different scenario. If you're a male listening to this podcast, if you happen to have a baby after having one of our epidurals, please let us know, because I think we can all make a lot of money together getting on national TV. But just kidding. And so we're going to take a real quick break, hear from our sponsors, and then we're going to kick it off with segment 2 of this episode.
At Premier Pain Treatment Institute, our patients always come first. Our board-certified physicians are experts at the treatment of chronic pain caused by various medical conditions, including cancer. Our goal is not only to relieve your pain, but to restore your quality of life. With locations in Hillsborough, Loveland, Middletown, and Mount Orab, there's always a location near you. We accept nearly all insurances, including Medicaid. Call us today at 513-812-PAIN or visit us online at premierpaintreatment.com.
All right, we're back with the second segment of our episode. We're talking about misperceptions in pain management, and I think one of the misperceptions we have in our specialty is where we can get placed in the algorithm. So just like the general public may be confused about the options that we have, and I think some of our own medical providers in our area have the same misperception. So they may associate us with only the medication management side of treatment as well, and they may send to a spine surgeon or another surgical specialty for an evaluation, when realistically we could probably achieve a lot of the conservative care more effectively. And then if they fail that, then we can send them to surgery. So rather than primary care sending them to the surgeon, who then sends them to us for the injections and then back to the surgeon, much more smooth pathways to go right from the primary care to the most conservative options to us, then to surgery if they really need it. So we'll start with April. When we have if you're necessarily a primary care doctor and you're seeing someone who comes in with a new back problem that just started, realistically, what kind of pain is that? Is that an acute pain or a chronic pain? And who would you send to, like, really first and foremost to help get them some good relief?
So if a patient is coming to primary care and their pain is all of a sudden, or within a week or so, usually that's considered acute pain or like a new onset pain. The ideal location or place to start for their plan of care would be therapy, imaging, and then sending them over to a pain management office to try to help with their acute pain, whether it would be with an epidural or any other intervention that we have to offer before sending them to, a different area for a consult. So really trying to just figure out, what's the cause of the pain, what caused it, was there a certain incident that triggered the onset of pain, or was it something that gradually came along?
Yeah, exactly. And so realistically, trying to get this acute pain, if this is in the first 6 weeks, you're trying to get it resolved and try to get it to go away and not become a chronic issue.
Mm-hmm.
And so when you send to the surgeon right away, and they take a few weeks to see the patient and then send them to therapy and then send them to pain management and other things, that really risks letting this become a chronic condition before it really can get addressed. So it can be a very efficient way to try to get in with pain management a little bit earlier. And then, Lindsay, one of the things that I'm not sure if you've come across it yet with our practice yet, but we do mostly chronic pain, but we also can be really helpful for cancer pain patients as well. So when, with our specialty being more than medication management and being able to be procedurally based as well, Have you had a chance yet to come across any cancer pain and some of the options that we might have for cancer patients?
Absolutely. And it's a tough situation to be in because it's obviously a whole different set of circumstances. But it's a different type of pain. You know, you've got people that are dealing with something that I mean, it's obviously not acute. You know, it's something that they're dealing with for an imperceptible length of time, I guess. But you know, after having medication, after having surgery, after having chemotherapy, you know, a great option would be something like a pain pump to where it's implanted, it is delivering medication on a constant basis at a regulated flow, at a regulated dosage through their system, for something that pain that's maybe more diffuse, something that you can't really put your finger on, and is certainly a little bit of a higher demand or a higher level than you know, a more typical, I guess I should say, scenario. And I think that a lot of times that's not something they've heard of before, or they might think, well, that's not for me. And rather than having these medications that are sedating, that are, you know, possibly depressing respiratory drive or causing these other types of side effects, it would be very effective for them to have that to help them live their lives without some of the aspects of medications that might be, you know, offering some of the less favorable part of I guess pain relief. So you know, it's not something that I knew of until I got into this role. But I'm kind of honored to be able to discuss that with patients because it can be eye-opening to them that there's something like that out there that can help with their pain.
Yeah, absolutely. So, you know, one of the big problems with cancer pain is you start to really escalate the doses, the side effects really become limiting and really you know, you can only really achieve so much with oral medication. And so the pump is very adjustable, very, you know, very low on the side effect profile, so you can adjust it quickly to titrate it to where it needs to be. And also, you know, when these patients, you know, when they get into remission and they now, you know, are back to living their lives again, but they still have some chronic pain related issues, they still have a resource right there to be able to continue to manage their pain afterwards as well. That's not just medication based. So I think there's a lot of, you know, a lot of great things we can offer in interventional pain management. And with that, I'll kind of wrap our episode with a little summary. So, you know, interventional pain management is both medication management for chronic pain and cancer pain conditions. So we offer, you know, both basic injections as well as advanced pain procedures like spinal cord stimulators and intrathecal pain pumps. And then we also have minor surgeries like the mild procedure and SI joint fusion and some other great options. So when you're, you know, if you have chronic pain or if you have a newer pain that's lingering a bit, been through some physical therapy, you know, pain management may be a great spot for you before you need to move on to having the, you know, the surgeon try to fix you. So, and also we work well with our surgeons, so we're not trying to hoard our patients and hide them away anyways. You know, we want to help you get relief and get it as quickly as possible. So we'll do the more conservative options we can offer, but if you really need a surgical option, we'll pass you along to where you need to go as well. So with that, I'm going to wrap. This is Dr. Michael Danko, Dr. April Egbert, and Lindsay Link, PA, from Premier Pain Treatment Institute. We have 4 convenient locations across the northern and eastern Cincinnati area. We have a website, www.premierpaintreatment.com. And our phone number for those local trying to schedule an appointment is 513-454-7246, 454-PAIN, PAIN. Thank you all for listening and have a good day.